The session I'll be giving is divided into two parts, and now I'll proceed into the first part of the session. So by the end of this presentation, I'm hoping that you'll be able to describe the types of intrauterine devices, or IUDs. I'll be using the term IUD throughout my presentation. You'll be able to describe the efficacy of IUDs, discuss the mechanism of action of IUDs, be able to discuss the advantages and disadvantages of IUDs, describe the common misconceptions attributed to the use of IUDs, and identify who are eligible and who are not eligible for IUD use. So intrauterine devices, or IUDs, are one of the long-acting reversible contraceptive devices, and globally they are the second most commonly used modern method next to female sterilization, accounting for more than around 140 million users. However, their use in the sub-Saharan Africa is very low, with a use of 2% in Ethiopia, according to a recent DHS in 2016. And despite the strides made in the increment of use of contraceptive methods in Ethiopia from around 8% in 2000 to 36% in 2016 for all methods, the use of IUD has still been low, with an increment from 0.1 to 2% in the past 15 years. And this is attributed to different factors, including misconceptions that we'll discuss later on, but also related to factors like accessibility of the IUD services, which, since it requires providers advanced training of providers. So IUDs are small plastic flexible devices which are inserted into the intrauterine cavity for contraception, and generally are classified into two types: the copper-containing IUDs and the hormone-containing or levonorgestrone, progesterone-containing IUDs. So now we'll see the duration and efficacy of IUDs. So the copper-releasing IUDs is a commonly used one in Ethiopia, especially the Paragard Copper T IUD, which can last up to 12 years. So you can see that it's very effective for many years. But there are other types of copper IUDs like the Nova T, which only has effectiveness of about 5 years. But the levonorgestrone progestin releasing IUDs, especially the commonly used, the Mirena, is effective for 5 years. When we see their failure rate, the prevention of pregnancy it has very high effectiveness, with a failure rate of 0.6 for copper releasing and 0.1 for Mirena in the perfect user failure rate within 1 year, which is based on randomized clinical trials, while the typical user failure rate is 0.8 for copper releasing and 0.2 for Mirenas. So you can see these have a very low failure rate, and this slide shows this high effectiveness and low failure rate of the long-term reversible contraceptive methods, including IUD and Norplant. As you can see, both IUDs and Norplants have a very low failure rate and low pregnancy rates, even as similar like the female sterilization. So in most of the presentation, we'll be focusing more on the copper IUD, as that's the commonly used IUD in Ethiopia. So when you see the IUD itself, it's shaped in a T form with copper sleeves in the arms and a copper wire on the stem of the IUD with a string thread, and the plastic is made of polyethylene. And this picture showing the palm holding the IUD is to give you the idea of the size of the IUD. When we go to the mechanism of action of IUDs, primarily both copper and hormonal IUDs prevent fertilization. So copper IUD creates a hostile environment with a foreign body effect, which results in inflammatory reaction, which reduces sperm motility and viability of sperm, hence preventing fertilization. Copper is also known to be toxic for oocytes, so this impairs oocytes and inhibits their ability to fertilize. So primarily it prevents fertilization. But in the event that there's fertilization as a secondary mechanism of action, it also inhibits implantation. So these mechanism of actions are what may also make copper IUDs also to be able to be used as an emergency contraceptives. When we see the hormonal IUD, primarily it also similarly inhibits fertilization. The majority of cases, through the endometrial suppression effect of the hormone, it causes cervical mucus to thicken and hence inhibiting sperm motility and function. As a secondary mechanism, similarly, it also inhibits implantation. But both IUDs do not have any post-implantation effect. And to give you a highlight of what are the benefits of copper IUDs, so as we have already seen, they are very effective, highly effective methods with a very low method failure. They can be used for long term. Once the IUD is placed in the woman, and there is no ongoing effort required by her, which makes it more suitable for use. And also it's effective immediately after insertion, requiring no backup methods. Generally, it's known to be cost effective, and when there is a need to remove it and conceive, then there's a fast return to fertility. Also, for women who are breastfeeding, it does not affect any breastfeeding because specifically the copper IUDs don't have any hormones. It's not user or also not partner dependent. As I've mentioned earlier, it can also be used as an emergency contraceptive and has been very effective if used within 120 hours or 5 days of unprotected intercourse. The copper IUDs have no hormones, so this lack of hormonal exposure also helps in continuing the cyclicity of the menstrual period, which is helpful for some women who feel anxious with the irregularity of menstrual cycles from other hormonal methods. It has also been shown that there is some protection effect against endometrial cancer. So we'll see the disadvantages or side effects of copper IUDs. So the IUDs do not protect against upper genital tract infections or HIV. The other is, especially in copper IUDs, specifically in copper IUDs, the average monthly blood loss from menstrual period is increased by up to 50%. With some spotting and cramping, but this is mostly seen in the first few weeks of insertion and generally improves after 6 months. Some women may have psychological discomfort of having a foreign body inside, and it requires a trained provider, so it may impact the accessibility. Risk of pelvic inflammatory diseases is increased, especially if the woman has a recent sexually transmitted infection or high-risk lifestyle. We'll discuss more about this in the next part of the presentation. And in rare cases, during insertion of the IUD, the woman may go into a syncope or a vasovagal episode. And other rare complications, which we'll discuss in detail in part 2, are missing of string or expulsion of IUD, pregnancy or method failure, which could be intrauterine or ectopic, rare cases of perforation, and pelvic inflammatory disease with or without ovarian abscesses. So as we have seen earlier, the use of IUD is generally low, and some of the factors attributed to this low use of IUD is the misperceptions and myths associated with the use of IUD. The first is that there's a tendency to think that the IUDs are not safe due to different reasons. One is that it causes a myth or misperception that IUD causes infection. So there has been a very big WHO clinical trial on more than 25,000 IUD users, which has shown that there is no baseline increase of pelvic inflammatory disease with women who use intrauterine devices. There is an increment of risk of infection in the first 20 days of insertion, which has shown that it was not related to the IUD itself, but to the insertion process related to contamination or with a related to pre-existing sexually transmitted infections. So in generally it's been shown that the IUD use does not predispose to infection. Also the same related to infection is post-infection infertility is one of the misperceptions. Ectopic pregnancy is also one of the fear for having IUD. Use of IUD prevents all forms of pregnancy, so in general it reduces the risk of any ectopic or intrauterine pregnancy. So, but in the rare event that a method fails while a woman is using IUD, the risk of that being an intrauterine, the risk of that being an ectopic pregnancy is higher, but overall it protects against ectopic pregnancy. And there are other the other reasons for being unsafe is the cause for pain or causing a miscarriage or abortion or anemia, which do not have any evidence to back these fears. The other is that the use of IUD will require restriction of physical activity, especially in societies like Ethiopia, where most of women in the rural areas are doing a lot of physical activities, including farming and other household activities. This misperception plays a big role. The other misperception is that IUDs cannot be used by nulliparous or adolescent women. This misperception is also actually prevalent in providers as well. Previously, the WHO had also put IUD for an adolescent or nulliparous as a category 2, which has changed now and can be used by nulliparous, and it has been shown that it is safe to use in nulliparous or adolescent women. Other misperceptions, like it will migrate to the abdomen or will get buried in the uterus, may increase transmission of HIV or PID if used by HIV positive women, are the other misperceptions. So during the counseling process, all these need to be addressed. So we'll now see what is the eligibility criteria for the use of IUD. This is just to briefly show you the overall medical eligibility criteria for contraceptive use for all methods, the 4 categories of eligibility, where we can categorize them as 1 and 2 being relatively eligible categories, and 3 and 4 being not eligible. So before I go to the different eligibility criteria, I want to pose this case of nulligravid adolescent for you to think about when we are discussing the eligibility, and we'll come back to it after we finish the eligibility criteria. So if a 17-year-old high school senior who has been sexually active with a boyfriend for 3 months, and she has been using condoms for birth control, but now she wants to use a longer term method but does not want to use a hormonal method of contraception. So would you consider IUD for this client? So those who are in category 1 and 2 for the use of IUD, any parity, be it nulliparous or multiparous women, are eligible for the use of IUD. Any age. IUD can be inserted immediately after abortion or after delivery, whether it's cesarean section or spontaneous vaginal delivery. The woman is not yet sure about a permanent method but wants a long-term method. For HIV positive women, but we'll see cases when it should not be used for HIV positive women. As an emergency contraceptive, as we have said earlier, women who cannot use hormonal methods can use copper IUD. Women with a previous sexually transmitted infections can use IUDs unless they are currently at high risk. Women who should not use IUD, or those who fall in the category 3 and 4, if the woman is known or suspected to be pregnant, if there is unexplained vaginal bleeding during the postpartum period, if it's beyond 48 hours but before 4 weeks of pregnancy, postpartum, there is a risk of high risk of expulsion and high risk of perforation in this time. If there is any sepsis related during the postpartum or post-abortion period, if the woman has a currently ongoing pelvic inflammatory disease or sexually transmitted infection, and a woman with a high risk of sexually transmitted infection, if she has an advanced HIV clinical disease with stage 3 or 4 according to the WHO classification, there is a current pelvic tuberculosis, also a woman with diagnosed with gestational trophoblastic disease or cervical or endometrial cancer, and any uterine cavity distortion from either congenital abnormalities or myoma is also a contraindication for the use of IUD. So when we come back to this case I posed earlier, I think you can see that copper IUD would be an appropriate option for this client. So I'll finish this presentation and then we'll continue with the next session. Thank you.